morning to everyone, and thank you for taking time out of your morning to tune in for the presentation. So occupational lung disease is quite a vast topic and, probably deserves a week's worth of lectures on its own. So in the next 30 minutes or so, I'm going to take you through a very brief overview of some of the common occupational lung diseases that we encounter within our South African setting, mainly looking at, which particular occupations are at risk, how they present, as well as the clinical and imaging findings. So given the vast array of other diseases and illnesses that we see, is occupational lung disease really such a big problem? So if we look at basically the global stats, it accounts for the greatest disease burden, mortality, and disability globally. COPD is caused by, besides being caused by smoke exposure, is also caused by particulate dusts, vapors, and fumes. We know of the association of asbestos with lung cancer and mesothelioma. We've also seen, at least particularly in the pulmonology department, a lot of work-related asthma, all the pneumoconiosis mainly associated with mining and dust exposure. Then the diseases caused by silicosis, coal workers pneumoconiosis, and asbestosis. And then lots of occupational infections. And I think we can all quite attest to the fact that we would all know at least one colleague who had suffered from pulmonary tuberculosis, which is common not only in healthcare workers, but also in silica exposed patients. So this diagram just demonstrates the change in the burden of disease from 1990 to 2017, with the top representing females and the bottom representing males. And if we look in the sub-Saharan and particularly Southern African region, we can see that over the last 30 or so years, not much has changed in terms of the disease burden. And this accounts for the fact that a lot of our workforce, that the mining sector particularly, is still a very strong sector within the South African setting. In terms of which disease burden is particularly common, again, looking across the various years, we can see that it's commonly the obstructive airway disease in terms of asthma and COPD that account for most of the disease burden, both in males and females. And again, if you look at our pneumoconiosis, we can see a lot of them relate to silicosis and asbestosis, of which people who mine in the construction industry are at high risk. And this accounts for both globally and across all the various economic spectrums. So the next thing will obviously, we need to look at who is potentially exposed and more particularly how these people are exposed. So if we look at this diagram, there are two main sources of potential toxic agents, and that include surfaces and air. And obviously for the purpose of this talk, or for lung injured occupational disease, we're going to look particularly at the air. And we can see that patients obviously inhale the particles into the breathing zone, and by inhalation, these then cause disease. And as we've all learned now, good barrier protection enables, good PPE rather enables protection from inhaled particles. So simple things such as a respirator will help to reduce the burden of disease. So the size of the particle obviously plays a big role in where it's deposited. So in general, larger particles, those in the 1 to 10 micrometer diameter range, as well as nanoparticles, deposit mainly in the upper respiratory tract, whereas particle size between 100 nanometers and approximately 0.5 of a micron are less likely to be deposited in the alveoli. And knowing the size of the particles involved can help to establish a connection between the workplace and the disease, and also helps you to determine what may be the proper method for monitoring the exposure and measures that should be applied to protect the involved workers. Furthermore, gases with very low solubility in water, such as oxygen, tend to follow the airstream to the lower airways, whereas gases with high solubility in water, such as ammonia, will tend to be absorbed and therefore affect mainly the upper airways. It's then obviously important to look at exposure periods and work histories. And this includes both recent and historical exposures. So not only what your patient is currently doing, but also what they did in the past. And respiratory diseases, whether they are work-related or not, can be aggravated by work conditions. An investigation of the work-related causes of the disease is important not only to the patient, but also to the colleagues in other workplaces. So if a particular manufacturer of a particular product is exposed, it's found that it increases risk of occupational lung disease within a certain sector. Other factories may be located in other cities or other countries can also be alerted to this, and they can take the necessary protective measures. Very high exposures to dust, fumes, or irritating gases can result in persistent asthma or the sudden onset of lung disease. And many occupational diseases are generally linked with a cumulative exposure over a long period of time. So even if you think you only, or the patient may only be exposed to a small dose of the relevant particle, if they are exposed over a long period, they still at risk for the development of disease. And even relatively low exposure over many years is related to an elevated risk of chronic illnesses such as COPD, pneumoconiosis, silicosis, and lung cancer. And this is just a brief overview in terms of how you would assess your patient, also looking particularly at exposures. So your main aim is obviously going to look at the diagnosis of possible occupational lung disease. So you'll do a clinical assessment, the appropriate diagnostic tests, and assessment of potential occupational cause. Then you look at the REP, which is a relevant exposure period. And this is based on the understanding of the latency, and I'll allude to that a little bit more under the specific conditions. You obviously want to take a good work history, look at the exposure assessment, and as I mentioned before, current or recent jobs, and also historic jobs. And lastly, you should always look to make recommendations both to the employee and to the patient in terms of how this aggravation can be reduced or how it can be prevented. So the first illness that we're going to look at is work-related asthma. So work-related asthma is divided into two big groups: work-aggravated or exacerbated asthma and occupational asthma. And occupational asthma further divided into IgE-mediated, those where we don't really understand the mechanism behind it, and then irritant occupational asthma. So it really depends on the molecular weight of the protein in terms of which of these categories they fall into, either IgE-mediated or unknown pathomechanism. So most of your high molecular weight proteins act through IgE-mediated mechanisms and a T helper cell type 2 immune response, so almost what we look as our typical asthma. The immunological mechanisms for most low molecular weight agents have not yet been fully characterized. And these agents normally are complete antigens, also known as haptens, and therefore they need to bind to carrier macromolecules such as proteins to become immunogenic, and they will fall more under the unknown pathomechanisms. So looking at sensitizer-induced occupational asthma, this is due to interactions between the environment and host susceptibility. And flour and isocyanates are the most frequent causes. So there are therefore a large number of occupations at risk for occupational asthma, and interestingly, including healthcare workers also. So the diagnosis of occupational asthma, so the gold standard is specific inhalational challenge, where if you can identify what you think is a causative agent, you can have the patient inhale it, and you can do spirometry to see how whether or not there's a reduction in their forced expiratory volume in 1 second. However, there's very limited availability and a high number of false negative results. You can also look at a clinical history. Importantly, here you want to see the association between symptoms and time at work. So patients may commonly say that they feel better once they get home or over the weekends when they're not at work, or for instance, when they go on holiday, they tend to feel better. But once they get back to work, they start feeling ill again. You can also look for reversible airflow obstruction on your spirometry. And this is defined as a post-bronchodilator FEV1 change of 12% and 200 moles, or non-specific bronchial reactivity during a methacholamine challenge. Fractional excretion or fraction of exhaled nitric oxide is also a very useful test, which unfortunately is not available at the moment, but it basically reflects eosinophilic inflammation within the airways. And more than 25 parts per billion generally tends to reflect that a patient has hyperreactive airways. And we can also look at the sputum eosinophil count of more than 1%. Fortunately, neither of these tests are available in any of the state sectors. If the antigen or the specific irritant is available as a skin prick test, we can do that, as well as look for specific IgE antibodies. And probably the most practical and useful is the serial peak expiratory flow recordings during periods at and off work. And what you'll notice is that obviously it will be a lot better when the patients are off work, and worse when they're at work. Normally we see about a 25% difference over a 4-week period of recordings will be diagnostic. So treating it, obviously, prevention is always better than cure. So you want to completely avoid the exposure. Unfortunately, this is not always possible. So therefore, you want to try to reduce the exposure, either by the patient, maybe asking the employee to reallocate the patient to a different task within the company, or if that's still not possible, then obviously then to suggest appropriate personal protective equipment. Pharmacological treatment can be used also according to international guidelines. And currently, both in the newly released South African asthma guidelines, which is in line with the CMJAH guidelines, the recommendation is SMART therapy, which is single maintenance and reliever therapy, which consists of a combination LABA-ICS, where the LABA must be formoterol, and then obviously you can titrate as needed. Despite using pharmacological interventions, it doesn't really prevent long-term deterioration. And there have been some studies looking at the use of anti-Ig monoclonal antibodies with mixed results. So next we look at work-exacerbated asthma. So that's asthma that is worsened, but not caused by conditions at work. There's 4 key diagnostic criteria here. So the presence of pre-existing or concurrent asthma. And concurrent asthma is asthma where the onset's while employed, but not attributed to work exposure. There's a temporal relationship between asthma and work. There are conditions at work that exacerbate the asthma, such as chemicals, dust, secondhand tobacco smoke, and grass pollens and molds. And the diagnosis is unlikely to be occupational asthma, as we've just been through before. It's generally associated with irritant exposures and aeroallergens, but can also be non-specific work conditions such as ambient temperature, strenuous work, and emotional stress. And if we think about most of the asthmatics that we see in the outpatients departments, they normally do complain that they have exacerbations with change in temperature and when they're very emotional. So work-exacerbated asthma may not necessarily be any different. So the key diagnostic steps is to establish the diagnosis of asthma and its onset. You need to demonstrate a relationship between exacerbation of asthma and work exposure. You need to exclude other diagnoses and identify triggers that may exacerbate the asthma. It's also key, as it was shown in the other slides, to look for other diagnostic mimics, and these include bronchial disorders, including reactive airway dysfunction syndrome, small airways and parenchymal disease, upper airway disorders, so including your vocal cord dysfunction, and other dysfunctional breathing disorders. So moving on to the next big group of occupational lung disease is the COPD, bronchitis, and bronchiolitis. So environmental exposures are the main contributors. And as we know, smoking is probably the most influential risk factor. But especially in our context, we must not forget biofuel exposure. An important proportion are also due to occupational exposures such as vapors, gases, dust, and fumes. In terms of the causative agents, you can see it's quite an extensive and exhaustive list. But if we focus mainly on the column on the left, we can look at the big groups. So it's combined exposures, basically, where there's numerous particles or chemicals within the compound that can precipitate or lead to the development of COPD, metal exposures, chemicals, including disinfectants and bleach, which we're using a lot of these days, minerals, as well as organic particles and dusts. So bronchiolitis is a chronic fibrotic pulmonary disease affecting the small airways. It was initially described amongst workers exposed to diacetyl in the microwave popcorn production industry and was actually initially called popcorn lung disease. And what they noted, why it was eventually picked up, is that, albeit be delayed, but there was a rise in case clusters. And the reason there was a rise, or took a while for them to pick up that this was actually an occupational lung disease, because this is a delay in its recognition as an OLD. There was no real work-related temporal pattern of symptoms. The healthcare organizations and the workplaces also failed to recognize the cluster of cases, the very complexity of exposures. There was no epidemiological characterization of the workforces. So bronchiolitis occurs mainly in the food industry, production in jobs or occupations where there's production of flavorings and coffees. Volatile structural related alpha dicarbonyl compounds are responsible, and these cause epithelial necrosis. They damage biological molecules and also perturb protein homeostasis. Now, we also see it commonly in cookie factories as well as potato chip flavoring plants, and also in occupations where there's processes involving pyrolysis and fermentation, such as manufacture of beer, wine, dairy products, and roasted coffee. Though interestingly, during the lockdown when SAB was closed, we didn't really see an increase in bronchiolitis, despite the fact that people were making their own homemade pineapple beer. There have also been case reports suggested by fiberglass reinforced plastic lamination. And also, interestingly, and I've seen quite a few cases now, and I think there was one also treated at Mole Park and Donald Gordon, of cases possibly due to the vaping of e-cigarettes. Then non-occupational risk factors. So this is what I alluded to earlier in terms of biofuel being such an important cause of COPD, and one that we certainly shouldn't ignore, especially in patients who have evidence of severe obstructive airway disease or pulmonary disease in the absence of smoking. So, unclean fossil fuels increase your odds ratio by 2.65 for COPD and 2.89 for chronic bronchitis, so almost a 3 times increased risk just from the burning of unclean fossils. And we see that the highest risk is in the African region and the Southeast Asia Pacific and Western Pacific, so mainly your low middle income countries, and use being much higher in rural rather than urban areas. So these patients are much more at risk. So moving on to the next clinical entity of asbestosis. So I think probably the one occupational lung disease that we're most familiar with. So the asbestos fibers pose a risk for diseases of the lung and pleura that can persist many decades after exposure. Asbestosis specifically is the interstitial fibrosis caused by the asbestos fibers, and I'll later on deal with the other diseases caused by asbestos exposure. There's no known threshold below which you will be safe, so kind of one exposure still puts you at risk. We haven't really quantified how much you need to clearly say you're at risk, but we do know that there is a dose-response relationship, so the more you're exposed, the higher risk of developing disease. The first case was recorded in 1907 in London, and it's now the most common form of the pneumoconiosis. So how does asbestos fibers cause lung disease? So the fibers are inhaled and lodged deep in the alveoli and bronchioles, and obviously therefore induce an inflammatory response as a foreign body. Phagocytosis is unable to completely clear the fibers. So some fibers, if you follow this arm, become coated and are known as asbestos bodies or fungus bodies, and these are thought to be inert. And then there are some uncoated fibers that then move into the distal interstitium of the lung and also the pleura, and these then further induce an inflammatory response, and we get apoptosis, oxidative stress, which increases cell signaling. We just get a chronic inflammation, the onset or rather the setup of chronic inflammation, and which mainly pushes towards a pro-fibrotic milieu, and we get fibrosis. So the physical characteristics of the fibers determine their deposition and persistence in the subpleural alveoli. The diameter of the fibers allow them to enter the alveoli in a laminar flow on the peripheral airways, and the long axis of the fibers prevent the phagocytosis by macrophages. There's 2 main types of asbestos fibers that we look at. There's a serpentine, which is also known as a chrysotile or white asbestos. And this is probably the most important one because it's associated with both of the diseases. And this one is long, curved, and flexible. And then we get the amphibole, which is the chrysotolite or the amosite, which is the blue and brown asbestos respectively. And these tend to be shorter, more rigid, and straight, making them stronger and more durable. I thought this was a very nice diagram just to show the relevant asbestos exposure in the different provinces in our setting. And, we can see a lot of them here. And relevant to us in Gauteng, we can see there are 2 hotspots, as well as in Northwest, which is a big drainage area also for us in terms of, we know that Clarksop and Sepang refer a lot of their patients to us. So it's important to know where your patient live in order to know whether or not they may have been exposed to asbestos. So in terms of asbestosis, it's largely non-specific in its presentation, and the diagnosis is really reliant on a detailed occupational history and your radiological findings. So in terms of key components, looking at the history, so obviously employment details are important. You need to look at the nature of the job, looking at whether they were in any high-risk industries, if they were using specific products that may contain asbestos. You must look at the method of exposure control. So basically, were they using any personal protective equipment? Then also non-occupational exposure. So this is something we mustn't forget about. So home renovations, was a family member in a high-risk occupation, or did the patient reside near asbestos mine or factory? And then exposure to other hazards also. All right, so if we look at the diagrams here, going from A to D. So A shows basically it's a chest X-ray, obviously, with bilateral widespread pulmonary reticular infiltrates. And there's also bilateral pleural plaques, which you can see here with this kind of increase of pacification, almost looks like veiling, but normally if you ask the radiologist kind of to do an oblique shoot through, you can see the plaques a little bit better. Figure B shows a CT scan demonstrating subpleural interlobular septal thickening within the lower zone. So all these fine marginations that we're seeing here, as well as pleural thickening, which we're seeing over here. Figure C shows basically again subpleural interlobular septal thickening with some honeycombing and traction bronchiolar ectasis. And lastly, in figure D, we see subpleural interlobular thickening, mainly, and a bit of pleural thickening also demonstrated over there. So these are typical findings in keeping with asbestosis. So in terms of how we diagnose it, so there's the updated Helsinki criteria, which uses structural pathology consistent with asbestos-related disease, documented either by imaging or histology, and evidence of causation by asbestos, documented through a good history, markers of exposure, and recovery of asbestos bodies, either by, you can do a bronchoalveolar lavage or transbronchial biopsy to look for these, and then exclusion of alternative possible cause. Treatment is largely supportive. Antifibrotic therapies are being evaluated, and there is a raised risk for lung cancer. So what you're mainly going to encourage your patient to do is smoking cessation. You want to look for any comorbid diseases, immunizations with influenza and pneumococcal vaccines, and obviously now COVID also. Important to evaluate for legal compensation. It can be quite debilitating, so these patients may not be able to work or have good quality of life, so you can look for compensation. And you need to longitudinally assess for any progression of the disease, as well as screen for other asbestos-related diseases, which takes us nicely into our next section, which looks at non-malignant pleural disease from asbestos, as well as malignant pleural mesothelioma. So starting off with pleural plaques, these are often incidental findings and are linked to exposure for more than 50 years, to past exposure more than 50 years. It's commonly smooth raised areas of hyaline fibrosis. They commonly occur bilaterally on the parietal wall of the chest, diaphragm or mediastinum, and obliterate the costophrenic angle. They typically don't involve the visceral pleura. And you can see sometimes, especially on CT scan, hairy plaques with a comet-tail appearance, and these indicate the involvement of the underlying lung. So we look at this diagram here. So figure A shows a small single pleural plaque here along the parietal pleura on this side, and the chest radiograph showing a calcified pleural plaque. And that's typically what tends to happen with the pleural plaques or the non-malignant pleural plaques. They're commonly asymptomatic, but can be associated with chest pain. You may hear pleural lab on examination. They have a small effect on functions of the lung, commonly causing reduced lung volume, but not gas, don't affect gas transfer. The next point was supposed to read that biopsy is generally not indicated because there's no specific treatment. There is a dose-dependent relationship has been demonstrated between crucidolite exposure and the frequency and occurrence of pleural plaques. The next disease entity is benign asbestos pleural effusion, which can occur on either side of the chest, but is very rare for it to occur bilaterally. Usually occurs after 10 to 20 years of the first asbestos exposure and is rare after 25 years of previous exposure. Lung function tests reflect the volume of fluid in the pleural cavity, which may sometimes be large enough to displace lung, causing breathlessness, and in which case those patients will require therapeutic pleurocentesis. It's generally exudative and blood stain, but otherwise has no real specific features. It's normally a diagnosis of exclusion, and it tends to resolve spontaneously, but may need repeated aspiration. And this basically the two scans on the, the X-ray on the right shows a conventional chest X-ray with the pleural effusion, and then we can see it represented here on the CT scan. Asbestos-induced diffuse pleural fibrosis or diffuse pleural thickening normally follows BAPE in about 40% of cases. But in most cases, the effusion may not be seen before spontaneous resolves. It can be unilateral or bilateral, commonly involving the visceral and parietal pleura, and frequently the costophrenic angle. It's an extensive progressive pleural fibrosis and can mimic malignant mesothelioma radiographically. However, compared to mesothelioma, it doesn't give rise to significant thickening of the mediastinal pleura. And commonly, you may need to do either a PET, CT, or MRI imaging or biopsy to make sure that you're not dealing with malignant mesothelioma. It commonly results in breathlessness due to extrapulmonary restriction and chest wall pain. And typically, patients may need opioid analgesia, nerve blocks, and NSAIDs to control the pain. And this is an X-ray and 2 CT scans showing diffuse pleural thickening either side, and then a very small effusion over here. So then malignant mesothelioma of the pleura. So this is actually in South Africa. That's why it's really such an important disease in our setting by Dr. Chris Wagner in 1959. And in 1962, we actually went on to show the induction of malignant mesothelioma experimentally in animals. He also found that crescidolite is more potent than amosite, which is in turn more carcinogenic than cresotile in a 500 to 100 to 1 ratio. It commonly occurs as a consequence of working in the mining, milling, and transport of asbestos, but there are a number of cases that have increased in builders, insulin workers, carpenters, and electricians. So I think it's very important for us. You know, we commonly just ask our patients, what do you do? And they say there's an electrician. But you should ask them, where are you working? Maybe in old buildings, old houses where there may be asbestos. Boiler makers, shipyard and sailors, mechanics working on brakes is also another profession that we tend to forget about, as well as even people who do it yourself at home. So like you say, if you decide, I should say a handy person. But if you decide to do renovations by yourself at home, you know, if you're not sure what the contents of your walls or your ceilings may be, you may be exposing yourself to asbestos. The diagnosis requires the histological presence of invasion of the chest wall, underlying lung or metastatic site. And cytology results, if your patient is frail, you can use cytology rather than biopsy to make the diagnosis. And the tumors are classified as epithelioid or sarcomatoid appearance, but many tumors exhibit both types. The sarcomatoid tends to confer a slightly worse prognosis, but overall malignant mesothelioma diagnosis has a very poor prognosis. So in figure A, we see a chest radiograph showing lobular thickening and an effusion in a patient with malignant mesothelioma. And the CT shows a pleural mass there with a small effusion and probable invasion of the pericardium. So as I mentioned, it's a very dismal prognosis. It's essentially fatal, with patients typically dying 9 to 12 months after the diagnosis, and chemo only prolonging survival to about 3 months. Surgical resection can be considered, but it really doesn't offer much advantage or improvement in quality of life. And surgery is very invasive. With the removal, you don't only remove the lung on the affected side, but often you have to remove parietal pleura, diaphragm, pericardium, and lymph nodes. So it's quite an extensive surgery. And many people feel the risk associated with the surgery and all the pain doesn't really improve survival and quality of life all that much. And in essence, it's mainly going to be for pain control and palliation. So I think from this section, if there's really one thing to take home, maybe it would be this table over here, just looking at the different asbestos-related pleural diseases, how they present and the specific findings in terms of radiology and how you may treat them. Then during my reading, I actually came across something quite interesting. So while the focus of this talk was mainly on occupational lung disease, so in terms of asbestos-related diseases, there is also, you can also claim if you feel you are in environmental claimant or within the environment around you, you feel you develop disease due to exposure to asbestos. And this is patients who have domestic or neighborhood exposure within 10 kilometers, but they have to find within the specific period, which is 1955 to 2002, because most of the mines were closed down after that. You have to send your claim to the trust and they will then evaluate it. And you must importantly have had no occupational exposure to asbestos, because then you go via a different, because then your company would be more liable, or the mining company, whatever company it may be, would then be liable to pay you out. And this is just this is actually done by the National Institute of Occupational Health, where they looked at environmental claimants. This is, I think, up to 2013 that they looked at. And then this is the number of people who put forward claims. Then coming on to our last section for today, it's silicosis and other silica-related lung disorders. So silica or silicosis was considered the king of the pneumoconiosis because it's a disease, human disease since ancient times. It was picked up in the pharaohs of Egypt, I think in a few other nobles in England and Europe also. And silicosis and silica-associated tuberculosis are the most important and most common occupational lung diseases. And I really want to highlight and focus this point. I know Dr. Graham at Hill & Joseph always used to reiterate it to us that silica and TB go together. This again is a nice just snapshot of all the diseases associated with silica exposure. You can see it's quite extensive, all the way from lung diseases, and also include infectious diseases, autoimmune diseases, renal disorders, and cardiovascular disorders. So really quite a multi-systemic disease-causing agent. So how does silica cause this damage? So its fractured surfaces interact with the aqueous medium, so that's this over here, and then generate oxygen radicals and injure pulmonary cells, particularly alveolar macrophages. Inflammatory cytokines then lead to inflammation and continued fibrosis. So basically this over here, this inflammatory milieu that we see happening at the bottom here. So sources of exposure. So this is, I think, maybe equally depressing as most of the previous ones, where there's a large number of occupations that are at risk for exposure to silica. So all mining industries, blasting with sand, construction, farming, and small-scale mining. And there's some cement, and there's some groups, what we call silica flour, where they're exposed to very fine grains of silica, including, interestingly, toothpaste. So the clinical aspects, so you've got to show that your patient had a sufficient exposure to respiratory crystalline silica. That's what RCS stands for. You must have comparative radiological features. You need to exclude alternative diagnoses, which this box on the year shows the extensive differential for what may look like silica-associated lung disease. And here's another important point to stress, is that sarcoidosis, TB, and lung cancer are impossible to differentiate on imaging alone. In these patients, rather, you often need to do a biopsy. So there are three main types of silicosis. There's chronic, accelerated, and acute. And most people feel that it's the same condition, just at different stages. So looking at chronic silicosis first, which is divided into two types. The first one is that of simple or ordinary silicosis. This is a long-term, low concentration exposure over 15 to 30 years, and generally progresses very slowly. Patients have small, round pulmonary nodules and visceral pleural thickening. If there's continued exposure, the nodules increase in size and eventually become confluent. and then change to then develop a fibrotic process, which can continue even if you remove the exposure. Patients are usually asymptomatic, but they may have some exertional dyspnea. And as the disease progresses and becomes more severe, more fibrotic, they become more breathless and also start to develop a cough and have increased sputum production. Complicated silicosis is where the nodules coalesce to become more than 1 centimeter in size. And these patients are much more ill, also going on to develop core pulmonale, respiratory failure, and eventually death. So figure A over here is simple silicosis. So these are very small, multiple nodules scattered throughout the lung. Whereas figure B represents complicated silicosis, where all the nodules have now coalesced and have now become basically more than 1 centimeter, and going on to develop PMF, or progressive massive fibrosis, and involving particularly the upper lobes, which is what is common in silica. So this diagram here on figure A shows progressive massive fibrosis on a coronal cut. You can see how extensive the fibrosis is, mainly affecting the upper lobes. And B, this is just an axial CT, again showing widespread peripheral and subpleural predominant reticulation. So that's all along here, indicating established fibrosis. So accelerated silicosis is essentially the same as chronic silicosis, except that it basically progresses a lot quicker. And you can really only diagnose it if you follow up the patient a few times to see that their symptoms or imaging are worsening. It's commonly found less than 10 years after the initial exposure, and it's probably a mid-phase between chronic and acute. What you see on X-ray may depend on the stage, but most importantly is that the changes are all rapidly changing, particularly looking at rapidly changing fibrosis. Acute silicosis, so this is known as silica proteinosis or secondary pulmonary alveolar proteinosis. And you get alveolar accumulation of surfactant occurs due to defective clearance impaired by silica overdose. And it's due to the fact that you get exposed to very high levels of silica, and this can be fatal. They generally have non-specific symptoms, and it's characterized by CT appearance, which we know of crazy paving and ground glass specifications. And if you do a alveolar lavage, bronchial alveolar lavage, you'll find numerous lamellar bodies and silica particles. So how do we go about investigating silicosis? So clinical examination, there's relatively few clinical signs, and you're mainly looking to exclude other causes. You may not necessarily clubbing, you may not see peripheral lymphadenopathy. So you're mainly looking to exclude other causes of the disease. Blood tests, there's no specific blood test for silicosis, but you can do blood tests to exclude other causes. Liver function and serum ACE may be raised in both sarcoid and silicosis, so that doesn't really help to discriminate between the two. The differential diagnosis, as I had alluded to on one of the previous slides, and then also your imaging, which I will go through a bit now. So the initial phases of a chest X-ray, you see multiple rounded opacities, which we can see all here. They're usually 3 to 10 millimeters, distributed predominantly in the posterior and the upper zones. They tend to be round and dense. And as the disease progresses and the nodules tend to coalesce, the size of the nodules may paradoxically decrease as they progress to progressive massive fibrosis. Calcification can also occur. With increasing fibrosis, the highlight become retracted in the lower zones emphysematous. And as I said before, PMF is difficult to distinguish from lung cancer infections. You may get hilar lymphadenopathy, which typically may show the eggshell calcification when viewed on a CT scan, and pleural thickening and pleural plaques may occur. High-res CT is more sensitive than plain chest X-ray, allows for better discrimination of PMF and emphysema and pleural disease. I just put this in all this imaging because it's quite interesting. This was a patient who we actually saw this week in the ward, who does have a very long-standing history of crushing coal for some odd reason. And as we know, coal patients who mine coal are at risk for silica exposure. So he's got what looks like PMF here, but he's also got numerous smaller nodules, which was a bit out of keeping, as well as nodules along the fissure here. And like I said before, sarcoid, lung cancer, and silica are difficult to differentiate on imaging alone. So this patient here, we weren't sure which of those three it was. So we actually took him for bronchoscopy, did washings, and a transbronchial biopsy, and we'll await his results. Lung functions tend to be non-specific, but interesting to note that the DLCO predicts emphysema earlier than chest X-ray changes. With progression, you can get any type of ventilatory defect. Serial lung function is probably more useful, and a decline in DLCO appears to correlate best with outcome. Bronchoscopy, bronchoalveolar lavage, and endobronchial ultrasound. So this is where we get to use a few of our toys. They're not routinely useful, but we mainly use them to exclude infection. You can do PAS staining to diagnose acute silicosis. You may see lymphocytosis with chronic silicosis, and we can do EBUS TBNA if we see mediastinal hilar lymphadenopathy and we're not quite sure what the cause is. Then other silica-related disorders, so there's lymph node silicosis, not commonly seen and may occur even in the absence of lung disease. Connective tissue disease with silica exposure. So basically, it seems as though almost all connective diseases are associated with silica exposure, including rheumatoid arthritis, systemic sclerosis, SLE, mixed connective tissue disease. Sarcoid and silicosis tend to go together. Diffuse dust-related pulmonary fibrosis, respiratory tract infection, which I would like to stress again, especially tuberculosis infection, lung cancer, and there's also increased risk of renal disease. So finally, to round up, just a few take-home messages. So unfortunately, there are a large number of particles who are associated with disease-causing potential. So therefore, it's important to take an extensive work. And I think also, in my opinion, also a good environmental history, because even within the setting that a patient lives, they may also be exposed to a lot of lung disease-causing particles. In terms of occupational disease specifically, you should look for temporality of symptoms with work hours, in terms of especially if your work exacerbating your occupational asthma. Encourage avoidance where possible, but if that's not possible, then just ensure your patient is using adequate PPE and try to assist your patients with compensation. So the email address is where we're currently using at the moment to send reports through and to be evaluated at the NIOH. And there's two links at the bottom, just in terms of patients who have asbestos-related lung disease, which they can follow in order to put in a claim.